to cause it. It just happens. And what happens, we think, we don't know the exact answer to this, but as your heart ages, it becomes electrically unstable, possibly due to micro scarring that happens just with age. Not a big heart attack or anything like that, but just tissues die, scar down, just like our skin gets defects in it and stuff as it ages, that kind of thing. And it sets up these unstable electrical connections inside your heart that cause it to start fibrillating, to where you're giving your heart's actually going about 600 beats a minute when you go into AFib. From the upper chamber, it comes usually from the left atrium of the heart. Now your heart can't beat 600 times a minute, so your wiring system has natural breaks in it, and typically if you're young, it'll go 170. If you're really old, sometimes it'll only go 80. I have somebody just saw their AFib is 80. So basically, it doesn't really matter, except that if it's going rapid, more than 110, 120 all the time, we don't like that, because even if you don't feel it, some people don't feel it, we'll slow it down with some medication. There's two big issues with the rhythm. One is you feel it interrupts your lifestyle, your quality of life is worse. Not going to kill you. That's, having it makes you, oh gosh, freak you out kind of thing. You just learn to live with that. You don't freak out. You just basically say, okay, I know what this is.
Right.
The life-threatening issue is not really the issue with that. It's the quality of life, trying to get you where you're not interrupted down for 2 hours because you're waiting for it to go away.
Right.
Okay?
Exercise, patient search, ED. Exercise.
I don't even know what that means. Never even heard that. So the other thing that everybody worries about, that you probably heard about, is stroke. Stroke is a risk with atrial fibrillation. We rate people's risk of stroke because, like I said, many people develop this rhythm. It gets much more frequent the older you get. By the time you're in your 80s, 10-15% of the population have had AFib. So it's an aging phenomenon, like arthritis. Think of it like that way. When you're really young and you have it, usually your risk of stroke is very, very low. It's less than 1%. It's less than the risk of the blood thinner that we give, that you hear about, to treat it.
Right.
Okay, and so we give you a ranked scale. Your ranking is 0. You have no risk factors. Those risk factors are, unfortunately, women have more strokes than men, heart failure, coronary disease or vascular disease, high blood pressure, diabetes, and stroke, history of stroke. So those are and age over 65, over 75, a point or 2 points. So we add all those points together. If you have 2 or more points, blood thinners are indicated. So by the time you're 65 and a woman, you're on blood thinners. By the time you're a 65-year-old man with hypertension, you're on blood thinners. If you're 75, everybody's on blood thinners. If you've ever had a stroke or a TA, you're on blood thinners. Those are the ways that we sort of work that. So otherwise, if you're otherwise healthy, you don't need blood thinners.
Gotcha.
Okay? Your risk of stroke is very, very low.
Okay.
So what we would do in the meantime is try to treat the quality of your life. And there's 2 steps that we can do, both of which I think we should do. One of them is start you on a medicine that sort of blocks. It could be diltiazem. I don't tend to use that. That's a great IV drug to use, better than beta blockers for that.
No,
But the better drug long-term is orally, I think, is a beta blocker. It will lower your heart rate down, lower your blood pressure. If you're symptomatic on that, well, then we'll just see what you can take. Sometimes just a little dose. It's not an antiarrhythmic, but that little dose sometimes we think will block the triggers for the AFib. Adrenaline surges, or maybe these premature beats some people have in their heart that might set up this rhythm. It's not really an antiarrhythmic, but some people, for some reason, just tend to get a lot better and they don't have a lot of it if you're on a beta blocker. So we'll start that.
Okay.
But I think you're young enough that you really ought to see a specialist for potentially what we would call ablation. You heard of that?
Yeah.
So
That's what Abby had.
oh, that's
Abby had it
my niece.
for a different kind of rhythm. Yeah, she was really young.
She was, yeah.
SVT,
She was
yeah.
under 20.
Yeah. So so that's the young person kind of rhythm called SVT. Those are great procedures. They love to do them. A few things we cure in cardiology. That's one of them.
Yeah.
95% cure when they do that. I wish I could tell you that it was like that with AFib. It is not. AFib is a much harder rhythm.
Yeah.
It comes from multiple sites. But I will say the younger you are, so if you don't have any structural heart disease and you're healthy, ablation's a good option for you because it'll keep you off medicines long term.
Yeah.
And usually you'll buy years.
Yeah.
So that would be the thing. I would refer you to talk to the guys about ablation. Start a beta blocker to get your quality of life a little bit better, hopefully, while you're waiting, because this is, unfortunately, it feels like an emergency to you. It ain't an emergency to cardiology. So basically, it's like having arthritis. If you were demanding to see your rheumatologist because I've got arthritis, they're going to tell you, I'll see you in 6 months. That's what's going to happen. So here it's just availability.
Right.
If you can drive to Winchester, you'll get. Did I just say Winchester?
Yeah.
God, I can't believe I said that. That's where I used to work 8 years ago. If you can drive to Charlottesville,
Yes.
they have 5 or 6 electrophysiologists there.
Okay.
Their openings are more available than you'll get here. We have one that comes here. He's very good, does ablations. But the guy's next appointment is in November.
Right.
Because he's dealing with all the pacemakers, all the electrical kind of stuff around here, and these special kind of ablation patients.
Right.
So if you wait for here, you're welcome to do that if you don't want to travel, but it's going to be a wait.
Yeah.
If you say, hey, gosh, we're happy to drive down to Charlottesville. Man,
We'll drive to Winchester too.
Well, I can see you there too. I know the guys there. But they'll see you, talk to you about the procedure. There's a small risk.
Right.
You don't usually jump to an ablation first because there is a small risk. But the people I do think about jumping to are people that are really, under 60 and nothing else going on, because I think that the meds also work very well.
Mm-hmm.
So alternatively, if you say, don't know if I really want that kind of big procedure, then alternatively what I have done is put people on a very simple medicine called flecainide. It's twice a day, and it helps. You can do one of two methods with that. You can take it every day, which is probably what I would tell you to do because you are having it at least once a week, right? If you're having it frequently, once a week is frequent. 52 times a year is frequent.
Right.
So you need to be on the drug all the time.
Right.
If you were having it a couple of times a year, I'd say you can do what's called the pill in the pocket method, where you take a dose as soon as you have an episode. You take a sort of a bolus dose, and sometimes it'll pop you out of the episode within an hour or two, and it's done.
Right.
Avoid an ER visit, that kind of thing.
Yeah.
That's not the best therapy for you, just because it's too frequent, I think.
Yeah. It is.
So you could choose, go on a drug, few side effects, very, very few side effects on the one I'm thinking about that I would use at your age. It is twice a day, gotta take a pill. Might not have that in addition to the beta blocker. We'd probably use the beta blocker first or both, and then I'd remove the beta blocker after you're on a good dose of the flecainide for a few weeks, and we just stop it and see if flecainide alone holds you.
Right.
And we can do that while we're waiting, and you go talk to the ablation guys too. You can do that too. So we got a couple, I'll give you sort of 3 options. One is just going a beta blocker, which doesn't have a huge success rate on blocking all of it, but may make it more tolerable so it's not as fast. I could add to that a rhythm medicine while we're waiting to try to suppress any arrhythmias or try to suppress the arrhythmias as best we can. The one advantage of that is by the time you show up for your EP study, if you haven't had a single episode, by the time you see them, it may change your mind on what you want to do. They'll talk to you about what to do. But if you go like, yeah, but it's gone now, I'll just take the pill.
Right.
But that pill is the rest of your life pretty much, though, right?
Yeah, it won't work forever.
Yeah.
Nothing
That's true.
in AFib works forever. Ablation, temporary. It comes back. At some point in your life, it comes back because your heart ages. There's a lot of muscle tissue in your heart. They fix small areas and try to isolate it, and then some other area pops up, 10 years later. But now is the time to probably consider that option. I don't send a lot of people to direct ablation for AFib because I don't have a lot of people completely well without having a stimulus, without having had pneumonia or something, and they went into AFib. And those people, I tell you, hey, you're going to get this again, but probably not until you get really sick.
Right.
And if you're young, wait till you get sick. And if we keep seeing it, then we deal with it.
Right.
But you don't have a stimulus, you don't have a provoked event, so you're just having it.
Now,
I said he was turning 50, that's why.
That's it, yeah. That's it.
So as far as like the frequency going up and down, long term?
Why is that? It's random.
It's just random.
Usually what happens is it becomes more and more frequent and more prolonged till it won't go away. Like
Right.
what you did when you came in.
Mhm.
It won't go away unless they shock your heart.
Right.
We electrically convert you. It'll
Mhm.
usually, that's the history. Sometimes that'll take 10, 15 years for that to happen.
Right.
Depends on how old you are.
Right.
If you're 75, I'm gonna tell you now you're gonna have it soon.
Right.
50, I mean, who knows? Maybe it'll quiet down for a while. Maybe something, you have a virus or something, it's just, we don't see it. It's just something irritating your heart, and it'll calm down with time. You'll have some time to think about that because you can't get in to see the guys really quickly. Anyway, you're gonna have another several weeks to
Right.
sort through how you think it's bothering you or not.
Yeah.
The most important thing is just to realize, look, you're very low risk of stroke. It's not life-threatening in and of itself, but it's an aggravation. I tell people, think of it like arthritis. If you're having a flare of your arthritis, no one rushes to the ER going, I'm gonna die,
Right.
right? They just realize, yep, they say, shoot, this is happening again,
Yeah.
that kind of thing.
Right.
So that's what it's gonna be like. It's just gonna be an aggravation. And we can treat the flares, or we can just try to suppress it so you don't have as much. Or we can try to get rid of it, although it's not going to be a cure. Don't ever go to ablation. They won't tell you that either. But if you go out in private practice areas, they're guys that'll tell you, oh yeah, I can fix this. They can
Right.
fix it
Right.
in the moment,
Right.
but
Yeah.
5 years from now.
So as far as like the symptoms of, like when it happens and I get lightheaded or, it's going up the stairs is
You're winning.
tough. You're
Yeah.
winded. It's because my heart's not efficient.
That's right. It's racing too fast. I mean, so think of it like if your normal heart rate's 70 or something, and all of a sudden it's 130. Sitting there doing nothing. So you're going to feel sort of more winded.
Yeah.
You feel like, and then when you're trying to do something, now it runs up to 170 really quick, when normally it would only go up to 100 when
Right.
you're walking, right, up the stairs. But now it jumps up to 170, so you get winded very quickly.
Right.
Lightheaded, if it goes fast enough, you can get low blood pressure that can happen, cause a problem. So
Yeah.
I think the reason they didn't send him home with the pill from the hospital is because they had him on that medicine from 5 p.m. on Friday until, no, earlier than that, 3 p.m.
It's probably 2 o'clock.
2 o'clock
2
until
o'clock.
about 8:30. And from 8:30 until they discharged us the next day, he never went back into AFib. But they had dropped it down from 10 milligrams to 5. And when they did that, he had 4 VT episodes in a row. And
VT episodes or AFib episodes?
the monitor said VT.
Yeah.
Okay, I'll look at that.
The nurse called us, or not the nurse, your doctor from Wellspring called us and said, had your heart continued to quiver like that, it could have been detrimental. But she went from 10 milligrams to 5 because she thought he was doing better. And then she came in and said, no, we need to put you back to 10 because your heart is starting to act weird. So she put it back up to 10. And then they kept him at 10 until 8:30, and then they took him off. And then he was off all night long.
Yeah, that shouldn't give them reassurance. I mean, I think they took it off because your blood pressure got low.
That's probably right, too.
And your heart rate's 50s without any medicines, so that probably gave them concern. They don't feel like they can start anything because your heart rate's slow.
Yeah.
Many times people's heart rate's slow. It's not. I mean, it doesn't matter. In a young person, if I start you on a medicine, your heart rate's 40. If
Yeah.
you're not symptomatic or lightheaded, that's fine. That's okay.
And then they did an echo the next morning, and they said that was like 50, whatever that number means.
Yeah, I was going to look at sort of see if I didn't see your echo yet. All right, let me get a couple of other things. How many kids?
2.
Any heart problems with them?
No.
Smoke, drink,
No.
and what kind of work you do?
Computer work.
And mom and dad, what, are they alive?
Yeah.
How old about?
77 and 70.
I guess 4, 3.
73 probably.
Dad 77.
Yep.
How old? Any heart problems with them? Heart attack, strokes, bypass, stents, and anybody? No AFib. How many brothers and sisters?
0.
I have a half sister.
Oh, that's true.
My sister, no problem with her.
No,
Any no surgeries?
just hernia surgery.
All right. Let's look here and see what that study showed. Let me look at that for a
Is it okay for him to start walking on a treadmill, riding a bike?
Yes.
There you go.
Doesn't have anything to do with your activity level.
Okay.
50 to 55% is low normal. It's normal.
Okay.
So ejection fraction's fine. Trace leaks of valve, pretty normal. That's just normal. Valves are not perfect, but really nothing on there. So that's a good thing.
And the monitor, the VT thing that showed 4 times was on Friday night, the 29th.
We think
That's the monitor you were wearing?
Yeah. We were glad that he had it on while he was in the hospital.
Yeah, no, those are...
Because it was nice to...
You had 3 triplets and 1 4-beat run of ventricular tachycardia. Those are very small and non-sustained. Maybe you had a virus or something. Beta blockers are a good thing to be on. They're unrelated to AFib. That has nothing to do with it. It's just something they found because they put a monitor on you.
Right.
The only thing I would do about that would be to do an echo. You already had that.
Right.
And you don't have any structural problems. Come on up here. Deep breaths in and out. Go ahead and lean back. No problems with chest pain, pressure, tightness, heaviness, anything like that?
No.
Hold your breath. You doing your regular exercise?
No.
He tries to walk upstairs. Like, we have 3 floors, so he tries to walk up and down those a couple times. That's
how about just yard work? Going on hikes, nothing like that? Don't do anything regular?
No.
But no chest pressure or anything doing activities you've noticed around your household or anything like that? Because of the ventricular tachycardia, which is a little odd to find that, I'm going to have you undo that. I'm going to have you do a walking test for me as well, just a treadmill, just to make sure there's nothing else odd going on. It'd be unusual for you to have coronary disease at 50 unless you'd smoked.
We thought maybe that happened because they were adjusting the medicine or something. We thought maybe
that was before.
Okay.
That monitor. That was before you were in the hospital.
That was during.
Oh, you were wearing you were wearing your home monitor in the hospital?
Yes.
Yep.
Oh, where are you going?
Okay.
Oh.
Now you're good. You're good. Let's have him get off the edge there. All right, good. So check your pulse down there. No swelling in your feet. Chronic stomach problems, nausea, vomiting, diarrhea, constipation.
Yeah, I usually have diarrhea.
Do you know why that is? That's an unusual thing to say.
No. He's had it for his whole life, I feel like.
Okay.
Well, I think it's kind of related to what I eat usually.
Have you talked to your family doc?
He's gone for an allergy test and he's almost allergic to some things, but he still eats them. So we think it's that.
Okay. All right, no passing out spells. Yeah. Never had a stroke, you said.
No.
All right, so everything looks good on your exam. What do you think? Do you want to go on? I guess my recommendation probably would be to go on we'll do a regular treadmill test, but I'm going to start you on flecainide, 50 milligrams twice a day, and then refer you to the EP guys is what I would recommend we do.
Sounds good.
Does that sound reasonable?
Yeah.
All right. You can always stop that appointment if you decide this is working well. You can always call if you're having a side effect from the medicine, then just stop it, call us, and let us know, hey, I'm having a problem. Heart rate slowing, could slow your heart rate some. You might get lightheaded. It doesn't really affect your blood pressure, but your heart rate could get slow. So if you feel lightheaded or you're having problems, now lightheaded with positional change, that's normal. But I'm talking about you're just doing your routine thing and you keep getting spells of lightheadedness. Let us know.
Right.
You just may not tolerate it.
Okay.
Now the medicine, the
Flecainide?
what's that?
Whatever this one is that they give.
No, the Deltiazem, yeah.
This
Oh,
one?
Lexapro. Who gave you that again?
The ER because of anxiety.
Do you have a problem with stress or anxiety you talk to them about? That has nothing to do with this, okay? Let me put it this way.
Yeah.
So you don't need to be on that from a heart standpoint. If you want to deal with that with your family doctor, that's what I would recommend. I would not let the ER manage your anxiety or depression. I think your family doctor should do that.
Yeah.
So if you feel like you're having problems dealing with stress at work, I would talk to them about that and let them give you some options.
Okay.
Yeah.
Okay. So that makes life a little bit easier so you don't have to take that pill.
So does he have to step down from it, or can he
Nope,
just stop?
you can just stop it.
Okay.
Now the medicine you're putting me on.
Yes.
Realistically, like you say, it's not going to last forever. Realistically, how long are we looking? Is it?
Oh, flecainide you may go 10 years without having it may control it very well. You may have a spell here and it may only last 15 minutes. I mean, you may go and have a spell every 2 years, or maybe have a spell every 6 months, but it only lasts for 15 minutes or something.
Okay.
So you don't know. I mean, everybody reacts differently. And you could decide. I mean, the only way to know this, time will tell, kind of thing. And the dose I'm starting off is on the lowest dose. There's 3 doses: 50, 100, 150. I'm starting on 50.
Okay.
So I would usually not give up until you're at least on 100 twice a day.
Mhm.
Depends on what your blood pressure and your heart rate do on it. So if things quieted down before that, you got down to see the EP guys and you go like, gosh, I haven't had anything in 6 weeks. Well, I mean, that does play into whether you want to, they'll talk to you about the procedure, that kind of stuff. If you have a high deductible health plan, you'll meet the deductible.
Well, I think we already met at the hospital.
Yeah, the procedure, it's so good. So if you've met your deductible,
Probably.
that's the time to do it because it's expensive. Very,
Yeah.
very expensive to get ablations done.
Yeah.
Tens of thousands of dollars. So they're expensive ways to proceed, and so I don't use them as they're sort of like a sledgehammer for a gnat if you're having very minimal AFib.
Yeah.
But if you're having it regularly like you were having,
Yeah.
and particularly if the medicines don't work, great option for somebody your age. Okay? So it's worth talking to them about,
Yeah.
getting an appointment down there. You'll get a 434 number from UVA. Don't screen it out.
Okay.
Yeah, that's them trying to make an appointment with
Okay.
you down at Fontaine in Charlottesville. They'll give you directions and all that. Now, in the meantime, if it keeps bugging where you're having long episodes, we'll just come to the hospital if you have to for a prolonged episode. If you're otherwise taking the medicine, the flecainide has no side effects to you, and you feel fine, you can take an extra one.
Okay.
And it may help to pop you, like I was telling
Okay,
you.
yeah.
I'm not going to use the beta blocker because your heart rate's low. I'm not going to use diltiazem either. We're just going to use flecainide. So, but you're going to take 2 a day, but you can take an extra one.
Okay.
If you're going, oh, there goes a spell, take an extra one right away. See if it goes away, hopefully a little bit sooner. It takes about 45 minutes to absorb something. So
Okay.
you're talking at least an hour to wait.
Yeah. Which sometimes, like you said, most of my episodes have been
They go away
hour,
quicker.
2 hours anyways.
In a long
Yeah.
time. Yeah.
All right. I'm going to have you come back in 6 weeks to see my nurse practitioner, Jimmy, just to make certain you're not having you're not having some problem on it.
Yeah.
You might or might not see them by then. EP may have an opening if they have a cancellation or something. They say, hey, we got an opening, because sometimes you look at the schedule, people have been waiting for months, but you happen to call when they
Yeah.
see an opening. So you just jumped ahead of the line.
Oh, yeah.
Right.
So if that works, great. But if you see Jimmy and you're feeling like, well, this medicine doesn't cause any problems at all, and I don't have any spells, I mean, you can cancel the appointment if you want to, if they've given you an appointment, but I don't think it ever hurts for you to talk to them
Yeah.
Yeah.
Yeah, for sure.
and sort of get a consult with them and say, hey, at least you know your options then. And then, let's say it happens 6 months from now, you're having more of it again on the medicine, they already seen you.
Yeah.
Right.
So now they don't really need to see you again. You can just say, I want an ablation.
Yeah.
And then I refer you down for the ablation because they know you.
Yeah.
So I think it's a good thing to do.
Okay.
And then we're going to do just that walk-in treadmill test just to make certain because of your little funny things on your monitor. It's just comfortable shoes, walk as long as you can on the treadmill.
Okay.
Oh, don't take the flecainide the night before and the morning of
Okay.
that test because I need to get your heart rate up.
Yeah.
So you got to walk on the treadmill till you get your heart rate up.
Okay.
They'll probably schedule that in a couple of weeks.
Okay.
Questions?
No, I don't think so. I mean, it sucks that, it's not really, like you said, there's no answer.
You're just old. Sorry, babe.
Yeah, if it makes you feel any better. I have this too. Yeah, I don't treat it very much. I treat it myself when I need to, kind of thing. Don't really see anybody. Just had it this weekend. So it's an aggravation I've been dealing with for 5 or 6 years. Hasn't been, not as frequent as yours, but it's just been aggravation. And I keep hoping mine's just gonna magically go away, which I know that's not the case. All right.
Well, thank you.
You're welcome. She'll be right in.